Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, I'm Theodore Leitch, a pediatric oncologist and associate professor at the Children's Hospital of Philadelphia and University of Pennsylvania. Welcome to this program titled Pediatric TRK Fusion Positive Cancer, Optimizing Care with TRK Inhibitors. Joining me for this discussion are Dr. Leo Mascarenhas, a professor and director of the Division of Pediatric Hematology Oncology and medical director of the Pediatric and Adult Sarcoma Program at Cedars-Sinai Medical Center. Welcome, Leo. And Dr. Daniel Orbach, associate director of Cerrito Oncology Center and chief of the Department of Pediatric Oncology at the Institut Curie in Paris. Welcome, Daniel.
Welcome, everybody.
We'll start with a brief overview of TRK fusion-positive cancers. The three NTRK genes, NTRK1, NTRK2, and NTRK3, include three closely related TRK kinases, TRK-A, TRK-B, and TRK-C. These kinases, which are involved in neuronal development in utero, normally signal downstream of neurotrophins, resulting in activation of the MAP kinase and PI3K AKT pathways, and ultimately cell survival and proliferation. In cancer, the most common mechanism of TRK activation is through inter- and intrachromosomal rearrangements, resulting in NTRK fusion genes. In these fusions, an unrelated 5' gene partner replaces the ligand-binding domain of one of the TRK kinases, resulting in constitutive expression and ligand-independent activation of the TRK kinase, which is oncogenic. NTRK gene fusions occur across a wide range of different cancers in both children and adults. In children, some rare cancers are defined by nearly canonical NTRK gene fusions, most commonly ETV6 and TRK3. These cancers include infantile fibrosarcoma and congenital mesoblastic nephroma, specifically cellular congenital mesoblastic nephroma. NTRK gene fusions occur at an intermediate frequency in papillary thyroid cancer. Other cancers are more common but harbor a low frequency of NTRK gene fusions, including other soft tissue sarcomas and high-grade gliomas. NTRK gene fusions have also been described very rarely in both ALL and AML. Given the profound efficacy that we've seen with TRK inhibitors in NTRK fusion-driven cancers, which we'll discuss in a few minutes, testing for NTRK fusions is critically important. There are a number of different tests that can be used, including immunohistochemistry, FISH, RT-PCR, and next-generation sequencing. Most of the rare cancers with nearly canonical NTRK gene fusions will have testing performed as part of the histologic evaluation of their tumor. For these cancers, testing may be conducted by immunohistochemistry, RT-PCR, or FISH, which are rapid and inexpensive tools that can identify these fusions when there is a high pretest probability that a fusion exists. While some studies have shown that immunohistochemistry is both highly sensitive and specific, in my practice, I've seen a number of both false negatives and false positives, and thus recommend that this testing is confirmed with a molecular method such as FISH. For other tumors, I generally recommend next-generation sequencing using an RNA-based assay. While more expensive than a single FISH test, this can identify both fusions of each of the three NTRK genes, as well as alterations of other kinases that occur in similar tumors and which are also highly targetable. Thus, this is an all-in-one test that can identify many actionable biomarkers. This testing paradigm is consistent with the ESMO algorithm for NTRK fusion detection that recommends that tumors which are known to have highly recurrent NTRK gene fusions be tested by a confirmatory technique such as RT-PCR or FISH. Other tumors are recommended to undergo frontline next-generation sequencing to reliably detect NTRK gene fusions if such testing is available. In situations where frontline NGS is not available, immunohistochemistry may be used as a screening tool. With cases that are IHC positive, then prioritized for next-generation sequencing or other confirmatory testing. Now that we've had this introduction, we'll review some of the clinical trial data for TRK inhibitors. First, I'd like to welcome Dr. Mascarenhas to discuss the data on larotrectinib that was presented at SIAP this year.
Thank you, Dr. Leach. Larotrectinib is a first-in-class, highly selective inhibitor of TRK, TRK-B, and TRK-C, approved for tumor-agnostic treatment in pediatric TRK fusion cancer. Here I will present some information from two clinical trials, the SCOUT phase 1-2 pediatric clinical trial of larotrectinib and the NAVIGATE phase 2 basket trial, which was also conducted in TRK fusion cancers. There were 137 patients less than 18 years of age with TRK fusion tumors who were enrolled on this trial. They were treated with larotrectinib at a dose of 100 milligrams per meter squared by mouth twice daily to a maximum dose of 100 milligrams. Larotrectinib was also available as a liquid formulation, which made possible for very young children to also participate. The primary endpoint for this clinical trial was the objective response rate as determined by RECIST or RANO, depending on whether this was a non-CNS solid tumor or a central nervous system tumor. Secondary endpoints included duration of response, progression-free survival, overall survival, and safety. Patients who participated on the SCOUT trial were also eligible to go on a drug holiday, and a wait-and-see analysis was performed to see what happened to these patients who were responding to larotrectinib and then ceased taking the drug. Of these 137 patients, the median age was just 4 years old. There was a slight predominance of males. Most patients had an excellent performance status. There were 38 patients with primary central nervous tumors, while the remaining 99 had solid tumors outside the central nervous system. The majority of patients actually responded or benefited from larotrectinib. The objective response rate for patients with non-central nervous system tumors was 86%, with 51 patients having a complete tumor response and 34 patients with a partial tumor response. There were only 3 patients who had progressive disease. Of those patients who had a complete tumor response and went on to have surgery, several patients also had a complete pathological response. Of the 38 patients with central nervous system tumors, 27 had measurable disease and had a response rate of about 52%. The response rate for treatment-naive patients was 40%. The 24-month disease control rate in central nervous system patients was 74%. 5 patients entered wait and see, including 4 patients with low-grade gliomas and 1 patient with a high-grade glioma. 1 patient with a low-grade glioma, did not continue to participate on wait and see for non-compliance reasons, but all 5 patients were alive at the time with no documented disease progression. So to compare patients with central nervous system tumors and non-central nervous system tumors, patients with primary CNS tumor had a median duration of response of 17 months, and those with non-CNS tumors had a median duration of response of 43 months. The median progression-free survival for patients with central nervous system tumors was 20 months, compared to 40 months for those with non-primary central nervous system tumors. The median overall survival was not reached for both groups, and the 5-year overall survival for patients with central nervous system tumors was 60 months, while those of solid tumors outside the central nervous system was 90 months. So to summarize this data, the median time to response for all patients was fairly fast, within 2 months with a range of 1 to 9 months. Larotrectinib was quite safe, with most treatment-related adverse events being grade 1 and 2. Larotrectinib demonstrated rapid, durable responses with a manageable safety profile. Thank you.
And now I'll review some data from ADVL 1823, which is a children's oncology group phase 2 study evaluating larotrectinib in patients with newly diagnosed infantile fibrosarcoma and other TRK fusion-positive cancers. This trial enrolled patients aged less than 30 years with any newly diagnosed TRK fusion-positive solid tumor who had unresectable measurable disease and had not received prior therapy except surgery. So this was really asking the question, can we move this therapy to the front line? Patients were enrolled to 2 cohorts. Cohort A was those patients with infantile fibrosarcoma and used a Simon two-stage design that sought to enroll up to 21 patients to evaluate whether the overall response rate was greater than 85%, which was the primary objective of the study, the central review overall response rate by RECIST 1.1 in those patients. Cohort B enrolled patients with other solid tumors and hasn't yet been reported, but should be available in a publication soon. Patients on this trial were treated again with larotrectinib at the dose of 100 milligrams per meter squared twice daily for 6 28-day cycles, and then subsequent therapy was based on their response. So those patients who had a complete response to therapy were treated for an additional 6 cycles or close to 1 year of total therapy, and then therapy was withdrawn and those patients were observed, really to ask the question, is this sufficient therapy for these patients, given that our goal is not to recommend lifelong therapy for young children? Those patients who had a partial response or stable disease, but whose tumors became resectable without morbidity, could undergo on-study surgical resection. And then if a surgical resection could be obtained, again, were observed off therapy at that time. Those patients who had metastatic disease or persistently unresectable disease that did not completely resolve maintained a treatment with larotrectinib for about 26 cycles or up to about 2 years of therapy, and then again were observed off treatment. And of course, those patients who had progressive disease while on therapy would come off therapy at that time. So what we saw was that there was a 94% objective response rate to larotrectinib within the first cycles for those patients with infantile fibrosarcoma. This included 1 patient who had a confirmed complete response and 16 who had partial responses, though there were other unconfirmed complete responses that just had not been confirmed at the time of the 6-month data cut. In addition, the only patient who did not respond actually had sufficient tumor shrinkage to be considered a partial responder after cycle 2, but because the study design required a confirmed response and no subsequent scans were obtained within the first month or 6 months, this patient was considered a non-responder according to the study protocol. We saw that these responses occurred early, with most responses occurring at the time of the first protocol-mandated disease assessment after cycle 2. And importantly, we saw that among those patients who had surgical resection of their tumor, there were 8 such patients and no such patient had tumor progression after surgery. Among those patients who did not have surgery, there were 5 of 8 patients who had tumor progression when therapy was withdrawn, all within about 3 months of treatment. So we identified that there are some patients who can maintain their response even without local control, but the majority of patients in this study who did not have local control went on to progress when therapy was withdrawn. We found that larotrectinib was well tolerated in this patient population. 7 of 18 or 39% had grade 3 treatment-related adverse events. The only recurrent such event was neutropenia. And there were other patients who had AST increase, anemia, and weight loss. 4 patients had dose-limiting toxicities, including 2 with neutropenia, 1 with AST increase, and 1 with weight loss. They all resumed therapy after dose reduction and continued treatment. And there was no surgical morbidity reported in this study where many patients had surgery shortly after stopping therapy. So next, I'd like to ask Dr. Orbach if he can present the data on other TRK inhibitors, entrectinib and repotrectinib.
Yes, thank you very much, Ted. The second drug that is very efficient in NTRK fusion tumors is called entrectinib. We wanted to show you a presentation that has been presented in ASCO this year that gather three group of patients that has been treated by entrectinib. One difference from larotrectinib is that entrectinib is a multi-tyrosine kinase inhibitor, which means that this drug may inhibit NTRK fusion tumors and ROS1 fusion tumor too. So this study gathering a patient that has been treated in Stark NTRK, NG, Tapestry, and Stark NTRK, two studies had exactly the same objective. The main objective was the objective response rate to this drug. And of course, secondary endpoints were the duration of the response, the time to confirm response, the clinical benefit rate, the progression-free survival, and the overall survival of all these young patients less than 18 with solid tumor and NTRK fusion transcript. If we only focus on NTRK tumor, 44 patients, the objective response rate was very good, around 72%, with 45 patients in complete remission, which was incredible in such studies, and as 27 in partial response. The median time to a response was very good, and you can see that the median time was less than 2 months in most of the patients. The median progression-free survival and overall survival was not available. What about the safety? There were some pyrexia in half of the patient, anemia, vomiting, and gastrointestinal trouble. I wanted to focus on two specific side effects that is quite interesting here. The weight increase, which is present in 1/3 of the patient. And the second thing is the bone fracture. Most of the side effects were reversible at the end of the treatment and were easily manageable. What about the bone fracture? This is a quite surprising side effect. Among the patients that had received entrectinib, 1/3, which means 27 patients, had a fracture. And the fracture seems to be, as usual, not so impressive, but this fracture led to the treatment discontinuation in some patients and interruption in others, 5 patients. The majority of this fracture resolved in patients, in 95% of them. Most of the patients were very young, and 78 had fracture related to trauma. So the next study that I wanted to show you is CARE, which has been tested the role of repotrectinib in TKI naive and pretreated NTRK fusion solid tumors. This drug has been given in patients less than 12 years old, and there were 3 cohorts. One was the first cohort was NTRK fusion tumor that were TKI naive. The second was a patient who had NTRK fusion tumor and received repotrectinib, but had already been pretreated by another TKI. And the third cohort were all the patients who had NTRK alteration. And the primary endpoint of the study was again the objective response rate, with secondary endpoints exactly the same as in the previous study. One important thing is that patients who were TKI naive has a better objective response rate, 60%, than patient who has been already pretreated by another TKI. The objective response rate in such a population was 25%. The toxic-related adverse events were anemia, gastrointestinal, and some of them lead to a dose reduction or discontinuation.
Thank you, Dr. Orbach. Now that we've reviewed all this data, I'd like to spend some time discussing how do we put all this data in practice. I'll note that there haven't been any comparative studies across these three different approved TRK inhibitors, but would ask my colleagues about the differences they see among these agents and how they consider them in particular with relationship to formulation or other ability to give these to children. Dr. Mascarenhas, what are your thoughts?
Most of my experience has really been with larotrectinib. I have some experience with entrectinib, with repotrectinib. In terms of entrectinib and repotrectinib, my experience has really been enrolling patients on those clinical trials, and patients have benefited from those medications. There are some concerns, related to fractures, which was seen on entrectinib, and it seems like the entrectinib data is enriched for patients who have central nervous system tumors and disease. And that's something which crosses my mind when I try to decide about how best to treat a patient with a TRK fusion tumor. The data with repotrectinib is still emerging and is much smaller than the other tumors, but I think just given the mechanism of the agent, if a patient becomes resistant to larotrectinib or entrectinib, I think repotrectinib becomes a very interesting drug to try in a patient with an NTRK fused tumor.
Thank you. And Dr. Orbach, when you're giving these drugs to children, are there specific unique considerations in pediatric patients, things like vaccinations or other things? How do you instruct your patients when receiving these agents?
Okay, to be honest, it's an easy drug to give it. So there is no specific real particularity that we need to inform parents when we start such a drug. Today, I don't know that. I think that there is no specific analysis on the value of vaccination, something like that. But when I give such a drug to a small patient, which is usually the case when you treat patient with infantile fibrosarcoma, I go on with the vaccination as usual without any differences. One important thing that Leo stressed is that we should consider that in very young children, as larotrectinib is available as an oral solution, it's an easy drug to give it at this age in very young patients. One discussion may be to give other drugs than larotrectinib, which means that today, as you may know, there are some discussion about the use of chemotherapy, conventional chemotherapy, in patients with infantile fibrosarcoma. But with such a very interesting efficacy data and the importance of this drug, I think we are, even in Europe, are switching to give such a drug in first line.
Thank you. Certainly, that's been our practice as well, that for those patients with infantile fibrosarcoma, with the data that we have, including the data from ADL 1823, that has been my recommendation as well for frontline therapy for patients. Are there other unique toxicities what you should think about in children? I know we mentioned weight gain, and we've also seen some withdrawal pain. Do you have specific strategies for addressing those, Leo?
I think the most common treatment-related AEs tend to be elevation of the liver enzymes, which are usually mild, and in those, and the other AEs, like usually a drop in the neutrophil count. Both those are related to the dose, and if they become intolerable, you could always do a dose reduction of the medication to actually help with it. I think fractures are a concern if they're mild. One of the issues are little children run around and fall often, and these children who actually respond to these drugs are like normal children. You don't really see them being affected tremendously by the disease. And so I think fractures can be seen, and it remains to be seen if these patients develop serious fractures, which can stop us from administering this medicine if it's serious.
I will say that sometimes I do see withdrawal pain in some patients, and in some of my patients, especially older patients who are able to report the symptom, I will wean the drug when we're discontinuing it, and that seems to be effective to decrease by about 25% a week. That is not published in any sort of recommended dosing algorithm, but does seem to have been effective in our patients. So I think we're almost out of time. Dr. Mascarenhas, would you like to present a case of a patient to highlight the efficacy of the TRK inhibitors?
Yeah, one of the earliest patients whom I enrolled on clinical trial was a 2-year-old girl who had a very large tumor in the left popliteal fossa, so much so that she couldn't flex her left knee or walk at that time. And a biopsy confirmed that it was an infantile fibrosarcoma, and FISH was positive for an ETV6 rearrangement. That patient had previously progressed on vincristine, dactinomycin, and cyclophosphamide. The patient had a partial response after 2 cycles of therapy, and then went on to have a complete surgical resection with no morbidity following 4 cycles of therapy, which is approximately 16 weeks. Following surgery, therapy was discontinued, and that patient remains well with no evidence of any morbidity or changes in her gait. Almost 9 years out now. Actually, November would make 9 years. And that's pretty remarkable, because the only operation she could have had if she did not have tumor shrinkage to control this tumor would have been an above-the-knee amputation. So actually, her response allowed her to preserve her limb and maintain function and lead a normal life. And more importantly, she hasn't recurred.
Thank you. That's really profound. So as we're running out of time, I just would like to conclude with a few remarks. I hope we've discussed and shown you how NTRK gene fusions occur across a range of pediatric cancers, and that testing for these fusions is critical given the very high response rates, and really, in some cases, as you just heard, life-changing activity of TRK inhibitors in these patients. We've talked about the safety of these agents, that they're generally very well tolerated, with mostly reversible mild laboratory abnormalities as their common adverse events, although we do need to follow the risks of fractures, and we need longer-term data on neurocognitive outcomes in patients. And that these agents are now approved across a number of different across really all cancers that have NTRK gene fusions. And so really highlighting the critical importance of testing all of our patients whose tumors may have these alterations for these critical fusions. I'd like to thank you, Dr. Mascarenhas and Dr. Orbach, for participating in this great discussion, and thank our audience for your interest and participation. Please continue on to answer the questions that follow and complete the evaluation. Thank you.